So now let's talk about atrial fibrillation. All right, so in atrial fibrillation, we'll go through, is what we're looking at is, let's erase that right there. So what we're looking at on this slide is, what do we see? Is we see no P waves. So if we went in close, we don't see any P waves, are not visible on EKG in someone with atrial fibrillation. Now it's irregular QRS complexes, meaning they're irregular QRS complexes. They appear at random intervals. Now, atrial fibrillation is increased with a 4 to 5-fold increased risk of stroke, as well as an increased risk of heart failure, dementia, and mortality. Why is there dementia? Just think, the supercomputer isn't getting perfusion. And increased mortality, you have risk of clots, risk of heart failure. Those are high mortality things right there. Pathophysiology, atrial fibrillation is driven by ectopic electrical activity, mainly from the pulmonary veins. So if you get a question, where is it coming from? If someone pimped you, where would the most likely would be? From the pulmonary veins. And then what happens is the atrium, the top part, the atrial structure, it's not doing well. It remodels. You get fibrosis, dilation, and electrical physiology changes that promote reentry. So it just gets worse and worse. This is a very important fact, is atrial fibrillation needs to be treated early because it can get worse, as we just discussed. Structural remodeling, fibrosis, dilation of the atrium. All right, let's go through and look at atrial fibrillation. Now, let's look at this drawing right here, okay? As you can see in this drawing, let's get a better look at it right here. So up here, we see this right here? See, we're getting signals all the way through, and it's throwing off what the atria is doing, as far as it's getting signals all over, and we'll have another drawing kind of. So signals, instead of a direct pathway right through the SA to the AV node. Now the EKG is the gold standard for diagnosis. You're going to have absent P waves, irregular heart rhythm, and neuro QRS. You can wear a Holter monitor, and that's going to help us, give us a long-term, it's not picked up on EKG. Echocardiogram will help kind of see what's going on with heart and structure-wise. And blood tests, which you want to consider, is the thyroid function. Probably get the basic electrolytes, because there's cases where patients will have electrolyte disturbances, and from these electrolyte disturbances causes atrial fibrillation. Kidney function too can affect the way if we're taking certain medications, it can build up in our system, or what we're excreting. So the pathophysiology is abnormal electrical discharge, multiple reentrant circuits which form within the atria, leading to rapid irregular heart contraction, atrial contractions. We have reduced atrial contribution, so you have this atrial kick, the kick for the atrium into the ventricle, resulting in variable and often rapid ventricle response. So you have variable and often rapid ventricle response. Causes: hypertension, coronary artery disease, valvular disease, congestive heart failure, hyperthyroidism, pulmonary embolism, obesity, diabetes, sleep apnea, excessive alcohol intake. Excessive alcohol intake. This is where they call it heart holiday syndrome, meaning that this occurs a few days to weeks after, say, the 4th of July, where people are increasing their alcohol intake. Pulmonary veins are a common source of ectopic beats, initiating atrial fibrillation. ABCs is anticoagulation, and we'll talk about the CHA2DS2 score. Blood pressure control, lipid management, and diabetes control. Now, the CHA2DS2 score of 2 or higher in men and 3 in women, we're going to say it's going to be 2 or higher, and I'll explain that later, is you need to put anticoagulation on. So treatment can be rate control versus rhythm. And it used to be as rate was superior to rhythm, and we'll talk about how that is changing. Now, what are some symptoms we can talk about? Palpitations. They're going to have weird feeling, of course, because their heart's beating irregularly. They can have fatigue, shortness of breath, dizziness, or syncope because the heart's beating irregularly. It's getting irregular output, and chest pain. Atrial fibrillation risk increases with age. What's the treatment? Rate control with beta blockers, calcium channel blockers, and digoxin. Rhythm control, antiarrhythmics can be used. Catheter ablation, this is where it's going to increase, and we're going to talk about why. Stroke prevention, need anticoagulation based on the CHA2DS2 score with greater than 2 or more for men, 3 or more for women, but basically we're say 2. Then a DOAC or warfarin will be initiated. Management of the underlying cause of what's causing atrial fibrillation. So what changed? So it used to be as rhythm control was number 1, or rate control was number 1. Now rhythm control with going to the EP lab and getting ablation is becoming, because there's been a change in technology. It's called the pulse field ablation. So instead of using in the past where you used heat or cold energy in a traditional ablation, the pulse field ablation, which is a catheter therapy, uses short bursts of high energy to affect the heart tissues that causes atrial fibrillation. These selective electrical pulses, primary targeting heart muscle cells, reduce the risk of collateral damage to the sensitive structures, including esophagus, and we'll talk about this why, the phrenic nerve, and blood vessels. So basically it reduces the complications. Less likely forming an atrial esophageal fistula. That's between the atrium and esophagus behind it, atrium esophagus behind it. That's what's happening under the old technology, and the cryoablation could happen. That was a rare risk, but it was a one risk. So basically the technique for ablation has gotten better and safer. And then we'll talk about why ablation is being used more and more. Atrial fibrillation. Usually atrial rate between 400 and 650 beats per minute, atrial rate. P wave not present, baseline wavy is seen instead. QRS is normal. Conduction, variable AV conduction. If untreated, the ventricular response is usually rapid. Our AFib with RVR, rapid ventricular response. That's where that term comes from. Rhythm, we talked about it, irregular. This is a hallmark of this dysrhythmia. Atrial fibrillation may occur proximally, but it can often be chronic. Proximal, we'll talk about this. So let's go here and let's take our algorithm of a patient with atrial fibrillation. Now first they gotta be stable, okay? If they're not stable, then what do? You shock. Now you can shock atrial fibrillation in normal sinus rhythm, but 99% will convert back into AFib. And so all the medications have side effects. Every medication we give as a provider, every medication you give is gonna have a side effect. Now you need to learn how to mitigate those side effects. Every medication has side effects. You drink too much water, you have side effects. So there's side effects in everything we do, and we need to mitigate those. When a cardioversion medication has a greatest risk of rate of torsades, so what, and we're gonna go through on these cardioversion medications, they have side effects too, and they also can cause arrhythmias. In anticoagulation, DOACs do a better job for adverse events and better mortality effects than warfarin, except for what? When do we not use DOACs? This is when the answer is metallic valves and mitral stenosis. Metallic valves and mitral stenosis, we do not use DOACs. All right, so then we come over here on our algorithm. We have the patient stable. So unstable, we shock. Stable, we control heart rate with intravenous agents, so we get the heart rate down. Now we assess how long have they had this arrhythmia. Less than 48 hours, so we can consider cardioversion and then pharmacology. More than 48 hours, administer anticoagulation, consider cardioversion after 3 weeks of anticoagulation therapy. Now you can also do a way sooner if you can do a TEE. In that TEE, you're able to look at the left atrial appendage, you're able to look at the valves better, you see if there's any clots in the left atrial appendage with a TEE. And if that TEE is cleared, then you can consider shocking at that time. Amiodarone, this is one of the, we'll say one of the chief antiarrhythmics used in the US. One of the top ones. Mechanism, well, that's a lie, because beta blockers are gonna be number one. But this is for antiarrhythmias, amiodarone is gonna be number one. Mechanism of action, it works on alpha, beta, sodium, potassium, chloride channels, slows down your AV node, slows your sinus activity. Lipophilic, so it's distributed, especially depending on the volume of your patient, is very large, so the serum concentration spikes and then rapidly falls. All the amiodarone goes into adipose tissue, so you quickly lose whatever you put in the serum. So just think about it. If the patient has more adipose tissue, it's going to get stored in there more. Has a very, very long half-life, about 100 days. So you got to be careful if they have toxicity to it, because when you stop it, it's still going to be in their system for 100 days. The load is how many grams of amiodarone to get them to properly treat the arrhythmia. That's when they have a steady state in circulation. So now, for the atrium to really affect the atrium, it takes about 6 to 8 grams, and the ventricle about 10 grams. There's a huge amount of iodine. So remember I said amiodarone, man, it probably wouldn't be approved today if it went through the FDA. It'd be a very tough approval process. One of the things it has high doses of iodine. 200 milligrams of iodine, and that's 75 milligrams per pill, okay? So 150 micrograms is your daily requirement. So that's 200 milligrams of iodine per pill. And then our daily requirement is 150 milligrams. So our intake is 50 to 100 times higher than daily requirement. So the main mechanism is that it involves a blockade of multiple cardiac ion channels, potassium, sodium, and calcium, as we talked about, as well as competitive beta-adrenergic antagonism. Amiodarone's use is limited by its potential serious non-cardiac toxicities, include thyroid dysfunction because of the high iodine. Both you can have hypo and hyperthyroidism, pulmonary fibrosis, hepatotoxicity. Pretty much everybody who's taking this for some duration is going to have corneal microdeposits. Can have skin discoloration, photosensitivity. You need to regularly monitor the thyroid, liver, and pulmonary function. And there's a lot of drug-to-drug interactions. Great drug, has side effects though. Now when we look at flutter, let's get that drone pan up, okay? We have right here is, this is mainly going to be a supraventricular, that means above the ventricle, supraventricular, above the ventricle, right here, above the ventricle. And usually can be in the right atrium, above the tricuspid valve in the right atrium. And versus fibrillation just kind of comes from everywhere. Look at this, all over. So as far as the treatment, when a patient goes to EP lab, flutter is a much easier treatment. You basically just have to break the rhythm right here. One in the isthmus, you basically destroy the tissue so the rhythm doesn't get through. In flutter, that's easy. In fib, it's harder because there's too many reentry points. Lots of different reentry points that can happen and make it where it's harder to fix in the EP lab. Atrial flutter is a supraventricular tachycardia. It's commonly involved the circuit in the right atrium that transverses the cavo-tricuspid isthmus. This produces a characteristic sawtooth pattern. You can see this here, like right here. We'll get to an area where we can draw on a sawtooth right here. See that sawtooth right there? See that right there? Sawtooth pattern of flutter waves in the inferior EKG leads. Inferior EKG leads. It has atrial rates in the 250 to 350 beats per minute with a variable ventral response depending on the AV nodal conduction. So how much from the atrial comes through to the ventricle. Atypical forms involve other atrial circuits, often related to prior surgery or scarring. So step one is you want to determine the AV conduction ratio to count the number of flutter waves, sawtooth patterns, occurring between each QRS complex. So on these we can see right here is 1, 2, 3. Okay, so this would get is 3 to 1. There's 3 flutter waves for every QRS complex. 3, here we go right here, 1, 2, 3, before each QRS complex. This is a 3 to 1 ratio. So in atrial flutter, talk more about this, is atrial flutter rate. So if the atrial rate is 300 and the ventricle rate is 150, there's a 2 to 1 conduction. 2 to 1 conduction refers to a situation where every other atrial impulse is conducted into the ventricles, resulting in a ventricle rate that's half the atrial rate. Make sense? So the atrial rate is going to be 300, the ventricle rate is going to be 150. Here, if the atrial rate is 300 and the ventricle rate is 100, it's a 3 to 1 conduction. And if the atrial rate is 300 and the ventricle rate is 75, it's a 4 to 1 conduction. Atrial flutter rate usually between 250 to 350 beats per minute. Atrial rate. P wave, there's atrial depolarization occurs in the rapid rate that has discrete P waves separate by the flat baseline that cannot be seen. Instead, the baseline rises and falls like this. This is the flutter waves, the sawtooth pattern. In these leads 2 and 3 of these can be quite prominent. You may create what's called a sawtooth pattern. You notice another key is if you see somebody and you're looking at the cardiac monitor and they're kind of just sitting at 150, you know that they have a dysrhythmia. And they just kind of sit at that 150. It may go down to 149 and way up to 151, but they keep saying, that's when you can start thinking, that's when you get your EKG and go, this may be flutter. The QRS is going to be narrow, normal, Conduction can be 2 to 1. It's the most common block. It means for every 2 visible flutter waves, 1 passes through the AV node to generate a QRS complex, and 1 does not. And blocks of 3 to 1 and 4 to 1 are also seen. The basic rhythm is regular versus atrial fibrillation. It's irregular, irregular. This is irregular. Atrial flutter may occur proximally, but is more often chronic. It is usually associated with COPD, CHF, and other heart disease. Treatment includes, you can try digoxin, you can try amiodarone, it may work, but you may have to cardiovert. The true treatment is going to the EP lab and slicing at that isthmus that we talked about. All right, now let's talk about acute anticoagulation. If DC cardioversion is not planned, do not usually need to acute anticoagulate with heparin. This heparin drip is what we're talking about, or enoxaparin, subcutaneous BID dosing, unless a patient is a high risk for thromboembolism and can start an oral anticoagulation. We're discussing DOAC. Now remember, if we start with warfarin, we need to have heparin initiated in the initial couple of days to our levels get to the proper INR. For patients who have been in atrial fibrillation for less than 40 hours, anticoagulation is usually not required due to clot formation is less likely. For patients who have been in atrial fibrillation for more than 40 hours or an unknown period of time, there are 2 methods that can be used. Patient can start an oral coagulation that we talked about for 3 weeks and then perform cardioversion. Let's go back to that. Or they can do is just get a TE as we discussed. If there's no thrombus, can do a DC conversion and continue a DOAC. If there is a thrombus, must undergo anticoagulation for 3 weeks prior to conversion and then continue. All right, now let's take a look at this. So when we do a TEE, we're looking at this guy right here. Get a good color so you can see it. And get yellow. All right, see it right there? That's your left atrial appendage. Now that's a remnant of our embryonic days, and it can sit in there, and what that does is that can cause blood to clot and form an atrial appendage. Now remember, is when the top chambers, the atria, are beating irregular motion, they're fibrillating like this, they're fibrillating, but they're not really squeezing. This causes blood to swirl and stay in the area. You can have blood pools, and these blood pools, and then you form clots. So when do we use a TE? We're looking at the left atrial thrombus, evaluation of valve dysfunction. You can see the valves much better in a TE. You can't see the left atrial thrombus and left atrial appendage without having a TE, and also is better for evaluating for aortic dissection. Now this is the CHA2DS2 score. Now this is a simple scoring system, and this is basically universal language. 2 or more, you're going to be giving a DOAC. There's some controversy at 1 of giving aspirin or just going to a DOAC. That's going to be further discussion. 0, you do no anticoagulation. So what is the CHA2DS2 CHF of any history or left ventricle ejection fraction less than 35%, you get 1 point. Hypertension, you get 1 point. Let's change it up to a red color so we can see it better. Age greater than 75 or equal to 75, 2 points. Age 65 to 74 years old, 1 point. So just think about it. Remember we said atrial fibrillation, worse when we get older. Increased risk of clotting. Prior TIA strokes, you get 2 points. Vascular disease, MI, peripheral heart disease, you're going to get 1 point. Female sex get a point. That's why I said it's basically 2 for female. They get, and then diabetes a point. So you add these up, 2 or greater, you need to consider a DOAC. Now we'll talk about when warfarin should be used instead of a DOAC.